Good day. I'm Elise Laila Blanca Flor, and I'm about to report the prolapse of the umbilical cord. Umbilical cord prolapse is a loop of cord that slides down in front of the presenting fetal part. It may occur anytime after the membrane's rupture and if the presenting part is not fully engaged or is not fitted firmly into the cervix. This is always an emergency situation because the reduced blood flow to the fetus can quickly cause fetal harm. Here are some factors why prolapse cord occurs. First, premature rupture of membranes. Because of this rupture of membranes, the cord tends to slide down into the vagina from the pressure exerted by the amniotic fluid. The second factor is that when the fetal presentation is not cephalic. Like what I said a while ago, that if the presenting part is not firmly fitted into the cervix, there will be slide down of the cord. The third factor is placenta previa. This is the low implantation of the placenta. The fourth factor is the intrauterine tumors. It prevents the presenting part to engage firmly. The fifth factor is a small fetus. It is somewhat similar when the presentation is not cephalic. Small fetus floats because of the amniotic fluid and tend not to engage firmly. The next factor is the cephalopelvic disproportion. It prevents firm engagement into the cervix. The next factor is hydramnios. This is the excessive amount of fluid over than 2,000 milliliters. The last factor why prolapse cord occurs is the multiple gestation. Upon assessment, cord may be felt as a presenting part on an initial vaginal examination during labor. Cord prolapse is first discovered only after the membranes have ruptured when the FHR pattern decelerates. The cord may be visible to the vulva. In ruling out prolapse cord, assess the fetal heart sounds after the rupture of membrane. It is either spontaneously or amniotomy. Therapeutic management. Cord collapse lead to cord compression because the fetal presenting part presses against the cord at the pelvic brim. Management is aimed toward relieving pressure on the cord, thereby relieving the compression and the resulting fetal anoxia. This may be done by placing a gloved hand in the vagina and manually elevating the fetal head off the cord, or by positioning the mother on a niches or Trendelenburg birch position, which causes the fetal to fall back from the cord. Administer oxygen 10 liters per minute. Using face mask to the mother is very helpful for the oxygenation of the fetus. Tocolytic agent. This can be prescribed to reduce uterine activity and pressure on the fetus. If the cord has prolapsed and has been exposed to room air, there will be drying and can lead to atrophy of the umbilical vessels. To reduce contamination, don't push back the umbilical cord. Instead, cover it with a sterile saline compress to prevent drying. When the cervix is fully dilated, the physician can choose delivering the infant using forceps to prevent fetal anoxia. Lastly,
if dilatation is incomplete, using the practitioner's hand, give an upward pressure on the presenting part until the baby can be born by cesarean birth.